welcome today. Hi, everybody. I'm Nina Crowley. I'm SECA's Professional Affiliations and Education Manager, and I'm super excited to be here with Dr. Angela Fitch, and we're going to be talking about the power of precision, how body composition assessment drives anti-obesity medication success. So it's a long title, and I know both of us can be long-winded, and we're going to talk about all of the things that we're both so passionate about. So I want to start by saying I reserve the right to let us go over by a little bit. This is going to be recorded and sent out to you next week, and if we don't get to your questions, we will definitely answer those in a follow-up email. But I'm excited to present my colleague and friend, Dr. Angela Fitch. She may not need an introduction, but she has been most recently at the Mass General Weight Center, and now she has co-founded and is Chief Medical Officer of Knownwell, which focuses on comprehensive, empathetic healthcare with a patient-centered approach without bias and shame. So all the things that we could imagine in a program. Her background's in first primary care and now obesity medicine, and she's currently serving as Obesity Medicine Association's president. And she and I met initially through the Obesity Action Coalition, where we both sit on the board of directors, and we've enjoyed collaborating together at all of our professional meetings, and we get to have a side of some fun when the meetings end. So I thought it's only appropriate for us to be both bike riding and eating ice cream and kind of collaborating after a conference we were at in San Diego for our picture to start. So thanks so much for being here.
Thank you for having me. That was a great time we had. I must say, that was a lovely day.
That was a great meeting. So I did just want to say the handouts for today's session are a PDF that is in the handout section of the webinar platform, so you can follow along and not have to take too many notes like I end up usually doing. You can put your questions in the chat or the questions tab. And if you're a registered dietitian, this webinar was submitted to the CDR for 1 continuing education credit, and I'm awaiting approval. So we'll send out a certificate once we get that approval, and you'll be able to claim your credits there. All right, so without further ado, I do want to sort of orient us a little bit to today's webinar. We're going to talk about the critical role of body composition assessment in maximizing the effectiveness of anti-obesity medications and its impact on treatment outcomes. We're going to explore feasible body composition methods and applicability in clinic settings so that we can empower our healthcare providers in designing personal treatment plans, and then understand the significance of muscle mass loss during weight reduction and discover interventions like resistance training and dietary changes to preserve muscle mass for long-term weight management. And we're going to do that by a kind of a more informal Q&A type format. So I'm going to ask mostly Dr. Fitch questions and kind of get her feedback. We kind of like this sort of fireside chat or podcast approach. I think, again, you and I could talk about these topics forever. So I really think this is a great way for our listeners to hear your expertise on the topic. So the first one is, why do we need to consider more than just weight or BMI in a comprehensive obesity care program?
Well, Nina, thanks again for having me. It's a pleasure to be here, and it's always great to sit and chat with you because, like you said, we could do this for hours. I wish we were doing it in the sunshine on bikes, but it's a little rainy here in Boston. I don't know about your neck of the woods, but thank you for all of you spending time, with us today over maybe your noon hour. But yeah, so, it's super important, right, to look at more than just, we talk about this a lot at the Obesity Medicine Association and other educational events that we host. That it's, the comprehensive obesity care is more than just weight loss, right? And I think probably most of our listeners right now are in tune with that as well. It's a chronic relapsing disease, requires lifelong treatment. It requires an evidence-based comprehensive approach with dietary interventions, lifestyle approaches, physical activity, as well as medication management and surgery often, as other chronic diseases do too. And so traditionally though, the world has focused on weight and this number on the scale and this BMI, right? And how do we get to that BMI when we know that was never the way BMI was created? It wasn't created to sort of be a number that you get to. It was a risk assessment. And again, we're looking at more than just weight loss, but other factors, right? Quality of life, being able to ride in an airplane seat without, needing a seatbelt extender. That was something my patient, was so excited about, that I met yesterday, right? That her job is that she travels around and takes people on different excursions across the world. And so travels a lot, and was so excited, so, grateful that she could get on the plane and not have to worry about it. And, so those things are certainly as important as the number on the scale.
Great. Well, I do think one of the things I was really excited about this year was that our professional associations have kind of started really to come together in a consensus, a consensus panel, or, really just coming together in collaboration to move obesity care forward. So I know you've been a big part of this effort. You want to talk about this a little bit?
Yeah, so we all came together. You can see all of our different associations. We've been working together for about a year now, and we're continuing to work together on coming up with these types of consensus statements around the disease of obesity, so we can all sort of be talking the same language and putting this type of statement on our website. The idea that body mass index is used to screen for obesity, right? The BMI was created as a number that showed that when you have a BMI of greater than 30 or greater than 35 or greater than 40, that exponentially your risk of other diseases increases. And we also know it's a J curve where the risk increases on the other side too. So when the BMI is too low, the risk of mortality and morbidity is high. And then when the BMI is too high, it is a screening tool that is useful to say, hey, this might be a problem for this patient, and how do we go about addressing that? And so again, the idea is that the BMI is not a measure of body fat, that it's really about the adiposity of the disease state of obesity that leads to this increase in mortality and increase in other chronic diseases, cancer risk, diabetes risk, other types of chronic diseases. So again, it's looking at that as a screening tool, but then saying, hey, how can we have better measures of the disease of obesity? And that's what we're looking at moving forward.
So I know you also, the OMA has been really involved in this, but I know that the AMA has recently made some policy discussions and decisions about BMI. And so I'd love to have you talk a little bit about that and how that's going to impact our professions.
Yeah, so the AMA, releases met in June, and at the Obesity Medicine Association, we're fortunate to have a seat on the House of Delegates. So, we represent patients with obesity and clinicians with obesity, essentially, at the AMA, and we consider that a very important role that we play, along with ASMBS, who also has a seat at the Board of Delegates. And so they met and acknowledged that there are problems with BMI and that we need effective alternatives to measure and defining the disease state of obesity, adopting this new policy that that BMI doesn't take into account different races and ethnicities, and that BMI cutoffs are helpful in sort of, as a estimating tool of the amount of adiposity or body fat a person has, but it may not be as accurate when it's used for, just individuals. Again, BMI was created as a epidemiological tool, not as sort of a, say, okay, you have a BMI of this, if you get down to this, that now you're healthy and normal, right? So I think the idea is to say, hey, we need more than just BMI. Then not to just throw BMI out the window, right? But to say, just like your blood pressure is just a measurement, that then can talk about, can sort of say to you, hey, maybe this person has hypertension, right? And so again, the idea is to use BMI as a screening. And this is a nice slide you have with the advantages and disadvantages, as I've just been talking about, right? The big advantage is it's very easily doable, right? It's just a height and a weight. And most of our electronic medical records now just spit it out. We don't even have to have those wheels we used to have. Remember the wheels we used to have to calculate it, right? And so again, it's very low cost. It's an adequate measure for epidemiological studies. And it's a screening metric, and that's the way it should be used. And it shouldn't be used as a number that people try to get to. We need a lot of more education of the general public too around this issue. That it doesn't account for muscle mass. But interestingly, at the recent ADA meeting, they just published some data showing that actually BMI tends to that there are more people in the country actually that have higher adiposity rates than their BMI. So in other words, their BMI may be even lower, but their adiposity is greater, indicating sarcopenia, which we'll talk about a little bit later, right? So, really BMI actually sort of underestimates today, not overestimates. There's been this sort of public opinion that, I have so much muscle mass that's why my BMI is high, right? But in reality, what we've seen when they do some research on, looking at ways of measuring body composition, that actually people that have even a lower BMI may have higher levels of adiposity and that may affect their health, right? And so again, I think identifying true markers of disease of adiposity is the future.
That's right on. And I think, these we can see here, these are some of the better than BMI or different than BMI measures that were suggested to use in conjunction from the AMA. So obviously, I think we're a little bit far away from exactly what they're going to be recommending doing, but these were put out there. And so I don't know if you want to talk a little bit about some of these measures and how we see them being used in healthcare.
Yeah, well, we've always had waist circumference, right? But I think one of the challenges of waist circumference, as another marker that is shown to be a good sort of, a marker of increased disease state, right? That's sort of, higher waist circumference, higher, waist to hip ratio, the idea that carrying this excess adiposity in our visceral adiposity in our midsection, right, is worse for us from a metabolic syndrome standpoint than other places in our body. So again, looking at that, where body fat is located is also important. And so using waist circumference is certainly also very easy and reliable and cheap, but unfortunately it's not very accurate, right? Like in other words, it's easy to mismeasure waist circumference. It's harder to measure people's waist circumference. And from time to time, if you're not using the same person to do it, that's another variable that gets inserted. So I think having these, having tools that are going to help us to actually identify adiposity, right, and also visceral adiposity in particular, is going to be important. So having actual discrete measures of these things is what the future is going to hold.
Great. So as far as the impact goes from the policy, I know it's probably too early to tell, but what do you see happening? How do people change that assessment or diagnosis, or what are they going to start doing in their practice?
Yeah, I think like the little diagram you have there, we're just sort of at the top of that, we're just sort of at this early stage of, we haven't really reached that tipping point yet where, I've said all along for many years that people should have a body composition, done for them, as a patient, on a yearly basis, let's say, routinely in many clinics, right? I mean, it's like to not be utilizing the technology we have today, it's challenging to, get technology into treatment, treatment paradigms in medicine. There's good data to show that in medicine, it takes like 20 years before something is adopted, right? From when it starts to when it gets adopted into medicine. Unfortunately, it is a field where sometimes it takes a bit of time before these things happen. But I think sort of we're at this point where we're getting more of this, more of these consensus statements, more of these things being talked about. So I do think it's right time for people to be utilizing some form of more formal assessment in the clinic.
Absolutely. I think as we're seeing, some of these better outcomes, I really do see, it's funny, we've heard for so long, this is, BMI is a poor surrogate for body fat or body composition or any of this. And so maybe it does feel like it's been several years, maybe not 20, but I do think it's really becoming more important than ever to know, what is the weight loss that people are experiencing, and in your experience with medications, I think that's what I'm really excited to hear you talk about is, now we have effective medications, but it's not good enough anymore to just say, great job losing weight. I don't know that that was ever the right thing to say, but, we've got to say sort of, where is that coming from? We don't want them to be worse off when they started. We finally have these treatments available. We want to keep them around without having, negative side effects, right?
And I do think the advent of more of these effective treatment options is going to drive some of this as well. You know, the idea around measuring, because um, you know, people have had surgery, right? It's less than 1% of people that qualify for surgery that get surgery. You know, surgical volumes are not that great, you know, in the country and the world, right? So while we've had people accessing effective treatments, and it's been less than 1% of those, you know, those patients that qualify. Now that we get more and more people accessing these more effective treatments that are producing the similar levels of weight loss as surgery is, right? I mean, that's where we need to, you know, I think, you know, start to pay more attention as well.
Right. And I know we'll talk a little bit about some of the medications and the side effects, but I know that the media loves to sort of say, oh, some of the serious consequences, and, you know, without fear mongering, right? We kind of got to do that in a balanced approach of, you know, these are some serious things we want to be looking out for, but we don't want to discourage, you know, that we want people to go to their provider and have that risk benefit conversation about, you know, what is the appropriate amount of risk versus the benefit, right?
Exactly.
Okay, so we've talked a little bit about this, and I did pull a lot of your or the Obesity Medicine Association's resources. I think they do a really good job with the obesity algorithm and some really kind of user-friendly, clinical applicable documents. And so I put some screenshots of those in here. But I thought you could talk a little bit about the assessment of obesity and how that's changing to include body composition.
Yeah, so we've had this in the algorithm for quite some time, because we have felt, you know, strongly that we should look at not only people's BMI, but, you know, their adiposity, their disease burden, if you will, of the disease of obesity, to try to risk stratify further. And as you know, too, we have the Edmonton obesity staging system and other types of staging systems put forth, you know, to also sort of stratify people into categories of what is you know, what's going to be appropriate treatment for them, because what are their ultimate goals, right? What are they trying to achieve? And so again, you know, assessing obesity with not only BMI, but with waist circumference, as well as percent body fat. And we have some sort of, you know, some normals listed there. And I think on, it might be the next slide where we have even more sort of, you know, these are some from some published literature, right? Some sort of ideas of where body fat should lie from a health perspective. This is really, though, you know, in its infancy. There was a recent publication too, you know, looking at mapping adiposity levels to mortality. So again, sort of emulating that sort of same J curve that was associated, you know, with BMI. We do see that happen with adiposity as well. So again, you know, we don't have the amount of race and ethnicity types of differentiators that we need today, but that's what people are working towards, right? Identifying, you know, not only sort of the levels that would be for more of a Caucasian population, but looking at these, you know, across all of different race and ethnicity, so that we can, you know, risk stratify that even better.
Great. Yeah, and I like the OMA's algorithm, kind of the way that you presented this body fat percent assessment, because I know, and I hear this question all the time, you know, what are the standard levels? What are we shooting for? What are we aiming for? And there is more text on there to talk about. This is from a few different sources, right? So there's not necessarily one across the board, like this is what everybody should be. And we do know that, you know, it's a good thing that we're taking into account, you know, race, ethnicity, and not just saying everybody should be at a 30% or less. So, you know, I think these are a good start and can give you kind of a benchmark for where you're going.
It certainly isn't the end all be all, and it certainly is at its, I think, at its infancy, if you will, you know, in terms of the level of research. But we need much more research on it so we can actually tell people, you know, give them some guidance. And again, also when I talk to patients, you know, it also isn't about, you know, like my own weight journey, right? I mean, I still live in the, you know, from a body fat percentage standpoint, I still live in the pre-obesity, you know, types of stage, but I used to live more in the obesity stage, right? So of a body fat level, right? So it's always about, you know, trying to optimize our metabolic health and our lifestyle, right? It's not about, you know, trying to feel bad about the fact that maybe I'm not in that acceptable range, if you will, right? Because again, it's about measuring this change over time. And and making that improvement, right, that has health benefits by itself, not just getting to a certain number.
Absolutely. So yeah, so kind of diving in a little bit to the body composition, what is the body composed of and how do you measure its compartments? I can tackle this one, or you
I'm
can
going to
take
throw
us
this,
down.
yeah, I'll throw this to you, the expert here in terms of this.
Well, I think this part is interesting. To me, learning a lot more about this, working with body composition in the ways that we measure the compartments of the body. So I think looking first on the left, we have our body fat and our fat-free mass. That's looking at those two compartments, and a lot of the measures are able to look at those two compartments. Now, when we're doing validation studies and looking at some of the ways we validate our measures that are more feasible to do in clinics, we look at a 3-compartment model where you're breaking out the bone compartment, and then the lean tissue mass is there as well as part of fat-free mass. And then when we look at a 4-compartment model, we're breaking that lean tissue mass part even further into protein and total body water. And I think that is easier to show when you look at 4-compartment model. So we do know that the gold standard for determining fat mass is looking at the 4-compartment model. So measuring those 4 predictors, the way that we do that for body volume, body mass, bone mineral content, or total body water, then we can kind of reduce the assumptions or the weaknesses that you have from an individual method. So you would, in a well-controlled research setting, you would measure all 4 of these body compartments and then see how accurate your like bioimpedance is against the 4-compartment model, and you get a % accuracy. So when you think, when we get farther into the presentation talking about the different methods, this is one way that you can tell that a feasible method is looking at this 4-compartment model. But I wanted to break that down even further because I think we hear a lot of terms in this field about, how we're measuring. And in the research, I can say too, there's a lot of use of these terms. So you're seeing fat-free mass, which again, if you're looking at 2 compartments, it's everything but the body fat. And that would include water, minerals, protein, glycogen. Then you've got the lean body mass, which I showed you on that middle 3-compartment model. That's without body fat and without the bone minerals. So that would be like a DEXA. It does still include muscle, other components like skin, tendons, connective tissue, and that can be variable amongst our populations. And then the water, non-bone mineral, protein, glycogen, and small amounts of essential body fat. So there is still a decent amount of other in that category. But I think what we're really getting at too is trying to look at, well, what is the actual skeletal muscle mass? What are the muscles that are responsible for voluntary movement that you actually are looking at being able to impact or, worrying about preserving as we're looking through a weight loss or weight intervention. And so maybe you could talk a little bit about how fat-free mass is, why that's important. Why is that the part that we're seeing a lot of research studies sort of focus in on it, and why we don't want to lose it?
Right. So fat-free mass is as you mentioned, is everything except for the fat, right? And those are the things that are most metabolically active, because that is our organs of our body, our brain, which is very metabolically active, right? Our muscles. And so again, our resting energy expenditure is reduced by approximately 13 kilocalories per day for each kilogram of muscle mass that's lost. So it is important also in that fat-free mass to break out that muscle mass and to try to optimize that muscle mass over the course of our lifetime, because we do know that we're losing muscle mass just every year, especially over the age of 50, by sort of default, right, if we're not using it. So if we're not doing some sort of resistance type of exercise or a routine, I mean, it could be activities of daily living too, someone who lifts, bales of hay, right, every day for their job, which, a lot of us don't do anymore as our jobs, right? But back in the day, that might have been, what people were doing more often was some of this heavy lifting. But again, the idea is that over time, we're going to lose that muscle mass. So trying to keep that reduction, keep that muscle mass is key to improving our resting energy expenditure. And there's currently no guidelines, unfortunately, that define, how much fat-free mass loss is excessive. So in other words, when we're looking at weight loss in general, we expect, and that's the big issue with lately, there's been a lot of talk about, oh, people are losing too much muscle mass, with weight loss, with some of our weight loss approaches or obesity treatment approaches. But we know in good studies that, there's this sort of idea of this, quarter fat-free mass rule. So in healthy weight loss, in healthy obesity treatment, the proportion of weight loss that can be attributed to fat-free mass is usually around 25%. I've always, used the sort of 30% number even, which is for every 10 pounds of weight that a person loses, typically we see 7 of that come from fat mass and 3 of that come from this fat-free mass, which also includes, some fluid, some other things, not just muscle mass loss. But again, the idea is that it's expected in weight loss to lose some of that. And so as long as it's within that range, we consider it to be acceptable, if you will, or, as the sort of goal is not to lose no fat-free mass, but the goal would be to lose less than 25% or less than 30%. Yeah, so I think, that's the gold standard is to try to, limit the amount of fat-free mass loss to less than that 25%, right? Or 25% or less, or even 30%. Like, like I've always been trained that 30% was also, considered to be acceptable.
All right, great. Well, then I'd like to hear a little bit more about, we talked a little bit about why visceral adipose tissue might be important, but tell us a little bit about the location of where adipose tissue is and why that matters.
Yeah, so, it definitely matters. Here's a nice, sort of look at MRI. You can see here when you look at that, if you look at the top left, where it's pointing to the subcutaneous adipose tissue, and then you work across and you see the more fat accumulating in the visceral adipose tissue, right, and across those segments. And so again, if a person's carrying more of their, weight in their subcutaneous area, it's certainly less of a risk factor for metabolic disease. But it still doesn't mean it's not a problem for them, right? As we mentioned, getting in the airplane seat and other types of fat mass disease things, osteoarthritis, carrying around that extra weight still may be impairing the person's function, right? So it's still important to, to acknowledge that for the patient. It's not just that the visceral adiposity is the only stuff we worry about, but when you can see that where more of that fat is accumulating in that visceral compartment, that's where we worry about it more as it relates to increased risk of cardiovascular disease and other types of metabolic diseases.
Great. And then again, like the body fat percentage graph that the OMA uses, I really like the additional table that you all have, kind of really looking at what would optimal and average visceral fat and android fat be. And so tell me a little bit more about this table.
And this is like, again, this is based on the best data we have today, right? It doesn't mean it's going to be the optimal forever. It gives you some guidance that, the sort of optimal visceral fat is to be in that range, of less than a pound. Most of the, a lot of the technology, as well as, the Sika technology gives us that in the form of liters, because it is a volume measurement, really. When you look at sort of looking at that on that MRI, right, it's a volume that you're looking at, which is easier to measure than actually, the weight of it. The weight of it is hard to measure unless you, aren't living anymore, and we can actually measure it in a scale. And so again, it's harder to estimate that. So estimating that in a volume basis in liters is how a lot of the current technology, would be giving you that data. But this is the idea of how to sort of look at that, overall.
Great. So then I think this is a big question that we hear a lot is then what should we measure, right? So if we're kind of going down that path that BMI and weight are not it as the only measures, what would be the best or of course in air quotes, right? Like what are better measures, right? And this is again from the algorithm getting us kind of moving in this direction.
Again, as we stated earlier, an increase in BMI, an increase in waist circumference, and an increase in percent body fat. All of those things correlate with increased prevalence of metabolic syndrome, but also increased prevalence of other diseases of obesity, right? Of mortality, of morbidity, those are the words we use, to say that as those numbers go up, those risks of those things increase. And so I think, again, as on an individual assessment, BMI is a reasonable initial screening measurement because it gives you that sort of say, hey, haha, maybe this person, is struggling. But again, it's not to say that a person of different race or ethnicity that might have a lower BMI should be just sort of, pushed aside and say, okay, it's not a concern for you. That's where waist circumference, we add that in as well. And then now I think that, the future is going to be looking at body fat percentage in one of these methods that we're talking about, because it does give us, for those patients who are at the extremes of muscle mass, it allows them to understand that, that they don't have a problem, right? Their BMI may be 28, but they are an elite athlete, an elite NFL type of, athlete, that they don't have an increased risk because of that extra muscle mass. And then on the opposite end, right, it also gives us those patients who have sarcopenia that have maybe a lower BMI but have an increased body fat percentage. So being able to measure that body fat percentage, I think, is really going to be the future of where we're going to go. It's just a matter of how do we get there.
Great. And then again, the top 10 that you all use is sort of the body composition takeaways. I think these are important, maybe not going through all of these, but wanting to show people some of these resources.
Yeah, I love the top 10 that I think I would credit this to Dr. Harold Bays, who came up with this idea to do sort of a top 10 takeaway message in each of the algorithm components. Just kind of gives people a high level of, what to, how to understand the different parts of the algorithm.
And so we'll go through in a little bit, but maybe talking briefly about, these couple measures that they call out here specifically.
Yeah, because DEXA has been the gold standard, so to speak, if you will, again, in sort of air quotes. I mean, it used to be, weighing in water was the gold standard, but that, quickly it got very challenging to do, on a routine basis, to have a giant pool, or something, to a big tub, to put people into. And then DEXA came available. So DEXA is still the gold standard of, what's being used in terms of looking at studies and outcomes. And that's why you'll see DEXA as the quoted type of measurement. But again, and then in the sort of older days from a accessibility in clinic, we had skin fold calipers, which is, what people may remember measuring from the old days, which is where they just pinched, how much skin do you have, back in different places, and correlated that with excess adiposity as well. But that, of course, has come out of favor just because we have much better ways of doing it today. And bioelectrical impedance, I think, is the most functionally easiest to do in clinic, which is why we're so excited about it, why we've used it for so long, because people can actually, just get on the scale and do this measurement. And of course, people are having bioelectrical impedance devices at home now. So more patients are having them at home. So understanding for clinicians out there, understanding what the patients are coming in with, when they're showing you their app, and being able to talk to people about that, I think is key, and talk about some of the, potentially the struggles with those types of devices, et cetera. And then, the air displacement assessment, which is the BOD pod, which we saw earlier in the little picture, is again a nice measure, but it's very challenging to get people into that little space-like machine, and they can't have any very minimal clothing on, so they have to come in their bathing suit or underwear, type of thing, and get in that machine. And so for a lot of people, they're claustrophobic. They don't want to go in there. So the bioimpedance is really our best bet right now, at least on the market, for being able to measure it in clinic easily.
Great. Well, yeah, we'll talk a little more detailed about those in a minute, but I think one of the things I'm most excited to bring to everyone from you is to tell us a little bit about the newest class of anti-obesity medications, and then we can go into sort of really optimizing the treatment that we have now with some of our outcome measurements.
Yeah, so this, I think, is, again, what's driving some of the desire, some of the urgency to start to measure these things in the clinic, because as more and more patients are getting access to these treatments, which is great. I mean, we're glad more and more people are getting access to treatment. It's going to be important for us to, again, sort of monitor for excessive muscle mass loss in particular and monitor for sarcopenia, because those patients really do need to be educated a little bit differently. The drugs that we have today, you know, in our sort of older class of medication, Saxenda being listed there as liraglutide, our first sort of GLP-1 treatment for obesity, you know, that medication on average produced about a, you know, 8 to 10% weight loss. But now as we're getting up into Wegovy and Mounjaro for diabetes, but soon to come for obesity, not sure what it's going to be called, but as we get into these newer dual and triple agonist therapy, you know, more and more people are getting into the 20% weight loss category, which is very similar to our surgical outcomes. And so, you know, having the ability to really personalize that treatment and really give patients better education is going to be key.
Absolutely. And I know you talked a little bit about weight loss outcomes, so maybe you could expand on that a little bit.
Yeah,
more.
here's what we were just, you know, what I was just saying is that in the, you know, sort of our older class of medications, if you look at the orange bar, which is the drug treatment, you know, on average with our older medications, it was between, you know, 8 and 10% weight loss. You know, and so we still use these medications. I shouldn't say that the older medications are just, you know, not to be utilized, right? Because I do think there's a place for them, especially for people that are looking for that 10% weight loss, right? So for patients that only need that 10% weight loss or are looking to achieve that level, you know, certainly, you know, these are very good treatments for them. And it's still important, you know, to acknowledge, you know, especially if someone is starting at a level that has significant excess adiposity and not as much muscle mass, you know, again, providing that education in a differentiated way is going to be key, because as we mentioned earlier, not all weight loss is created equal, so to speak. Now we're getting into this effect where semaglutide and tirzepatide are up in the, you know, 15, 17, 20, 22%, and soon to come, even if it up into the 28, 30% weight loss category with our newer agents coming down the pike. And here's some data, you know, with semaglutide, right, which looked at a separate component of you know, patients that were going through treatment, right? And so you can see here, you know, on average there, that the total body weight change, you know, was around that, you know, 15 to 17%, which when you look at a person on average in the study, the average baseline weight was 230 pounds, which meant about a 35 to 40 pound weight loss on average. So again, you know, the idea that now, if you look at the bottom categorical weight loss graphs, we see now 32% of people getting into that 20% weight loss category or more. And those are the people, again, that we really need to be, you know, making sure that that weight loss is coming from the, you know, the right part of their, the thing they're wanting to lose, which is their adiposity.
Right. And then, you know, I know there's so much kind of coming down the pipeline, and I get, you know, really overwhelmed and excited to hear about that all, but I don't know if you have any thoughts about, you know, what we're going to see kind of moving forward.
Yeah, so this is just a quick, you know, look at what the future is going to hold. And I think that, you know, we have our combined GLP-1 glucagon agents that are being studied right now from Boehringer Ingelheim and others, pemvidutide. And then we have our triple agonists, retatrutide, which is from Eli Lilly, that is really, again, getting up into that 30% weight loss category, right, for more patients. So when we get up there, we really do need to, again, be mindful of, you know, how we use these medications and for whom we're using them in, so that we can, you know, have the appropriate outcomes that we're trying to get. As you mentioned earlier in the talk, we don't want to make people sicker, right, by having them, you know, have loss of lean mass and not enough, you know, not loss of their body fat, which is what we're trying to, you know, target. We're really excited about the small molecule GLP-1s, and because they are orally delivered and not as challenging to produce. It should be noted that lotiglipron was actually, the research on that has been stopped recently. That was a drug that they stopped research on because of some side effects, but orforglipron is certainly looking very promising in the next 3 to 5 years. And so, you know, having an oral agent that patients can take that has equal efficacy to some of our current injectable medications is going to be just make it easier to produce, easier to distribute, easier to get to more patients as well.
Yeah, and I think, the big question here is, so I don't see this talked about as much, and I know you and I have talked a little bit about digging into some of the studies, like the step 1 study here, to kind of figure out what's happening to body composition as people are taking these medications, both in a research setting, in a clinical trial, but then, kind of in real life, what are they going to see in the clinic? So this was from that subset of that step 1 trial looking at 140 patients who had a DEXA. So what are we seeing here?
Yeah, so, fortunately in the study, they did have these patients, subset of patients that had monitoring of their body composition. And so as we see more of this, I think this is what's going to, unfortunately, the headlines around this that came out in the media where people lose muscle mass, on these medications, they're not good for you, right? And then that's not the point. That wasn't the point at all. We know, as I mentioned, that people lose lean mass. And again, this is looking at fat mass versus lean mass. And again, the lean mass includes not only the skeletal muscle, but other things as well, right? So it's not just skeletal muscle. So when you look at this ratio of a loss of 8 kilos here of fat mass in the semaglutide group, and approximately 5 kilos, that fits with that ratio of that sort of 30%, right? That 25 to 30% coming from that lean mass category. So it's not unheard of. This was essentially saying that, hey, it's actually falling in line with the same type of body composition losses that we see with other weight loss. It's very challenging. It's almost impossible to lose weight only in your fat mass compartment. And we know that scientifically, so to assume otherwise is unrealistic.
And I guess showing even in the placebo group which I think we always need to mention, is also getting lifestyle intervention. They're not just truly getting nothing. They're losing both, and even, more lean than fat in that group.
They did, right? And that, could have been just the subset of those people, but still, it just goes to show you that all weight loss produces some lean body mass loss. And I like those little, figures that you have down there where you can see that, the percentage of fat, right? These patients in the semaglutide group started with 43% body fat on average. And at the end of the study, they were 39.4% body fat on average. So again, the percentage of body fat relative to the rest of their body, the things in their body got much better, right? That's the big difference. And you see in the placebo group, just even though they lost weight, their body fat percentage didn't change. The percentage of fat to muscle, that ratio of that body fat percentage didn't get better. So that's what we're trying to accomplish.
And then here, the tirzepatide group.
Yeah, the tirzepatide data from SURMOUNT-1, right? They also had patients that had DEXA scans, 160. And, not all the patients got this evaluation because it's very challenging to get people in for DEXA scans, right? And so that's why you see these subsets, of these patients during these studies. Average weight loss was around 15.7%. The fat mass decreased 33 to 35%, and the lean mass decreased this 10 to 11%. And so 24% of the weight loss was from lean mass, which again is around that 25% rule, that we see. So maybe was a little bit better potentially than the semaglutide, meaning a little bit more preservation of lean mass in this tirzepatide group. So, maybe a potential there for a benefit, which we actually know may have some benefit with a tirzepatide in particular, because tirzepatide has been shown to potentially cause a browning of adipose tissue. So potentially there is an increase in energy expenditure with tirzepatide, not just a appetite suppression and weight loss from a calorie differential. So there is that piece of tirzepatide that has potentially metabolically a little bit of an advantage. And then we have bimagrumab. You have to practice that over and over until you get it right, everybody, bimagrumab. And so I think I'm saying it right. It's like potato, right? Or something like that, tomato, tomato. But this is a drug that's been shown to increase lean mass. Interestingly, if you follow along with what's happening in the world, Eli Lilly just purchased the company that makes bimagrumab. So It's a bit fascinating, especially because there's going to be a trial with semaglutide combined with bimagrumab. You saw that maybe on the earlier slide. So now, interestingly, Eli Lilly and Novo Nordisk are doing conjunctive research, which is, again, fairly fascinating in the obesity treatment space. But in this drug, it actually increases lean body mass. That's how it works. Being an antibody, it actually, a monoclonal antibody, that can increase lean mass while also producing fat mass loss itself. So it does both things at the same time. So one of the concerns around bimagrumab was that people wouldn't lose as much weight, and they would be, from just a number on the scale. So the data would suggest that there's not as much weight loss with bimagrumab alone. However, there's actually a better body composition, right, developing, because people are losing fat but gaining muscle at the same time. And so their weight number doesn't drop as much because of that differential in that 3.6% lean mass gain and 20% fat mass loss. So combining it with semaglutide is being researched, which will also be interesting.
And I thought too, after my many years working in bariatric surgery, where this has, been something that we've talked about and seen, and hopefully people are monitoring as well, showing a little bit about a couple studies and what we can learn from those patients and the way that they're losing weight.
Yeah, so, while we have never really focused a lot on doing body composition routinely in bariatric surgery clinics, it has become more prevalent, to look at that. But again, when they did studies looking at that, certainly it fell along with that same sort of 25 to 30% rule, right? So the average contribution of fat-free mass to total weight loss was less than 30%. So again, the majority of weight loss that's happening when we have these interventions such as surgery and our newer medications seems to be coming from the adiposity category, which is the good news. This is just showing that sort of proportion of fat mass and fat-free mass weight loss in surgery patients, showing that, again, there's more of a proportion of fat mass loss in the gray bars than fat-free mass loss. So again, we can say that when patients are typically on average, when they're losing this 20 to 30% of their weight, that the majority of it is coming in that sort of, you can see there, that 75-25. Or 70-30 type of rule.
And I think this one's important too, to show sort of change over time. A lot of people ask that, what's happening over the course of a patient over time. So this would be a nice way to show what's happening over 3 years.
And this just looks at the prevalence of excessive fat-free mass loss. So excessive fat-free mass loss. So again, you can say on average, people are doing the right thing, by losing this 20 to 30% of their body weight, that most of it is coming from fat mass. But what about those people that might be, how many of those people are losing too much in that sort of fat-free mass and category, which we would, again, worry that a lot of that is skeletal muscle or muscle mass, right? And we don't want to make people sicker. We want to make people stronger, and we want to make people, live higher quality lives and be able to, get up out of the chair when they're 90, which is why I work out, right? Because I want to be able to get up off the floor by myself, when I'm 90 years old. And so again, if you see this here, you see that those patients that are losing greater than 35% of their fat-free mass. So those are the darker horizontal lined bars there on the right side. Thankfully it's less than 10% of the, around 10 to 15% there by 36 months, so as they get out 36 months, the idea too that we think about is that patients also can gain back some of that fat-free mass. So when they lose that fat-free mass in the beginning, during the initial weight loss phase, I always tell patients, when I'm counseling them, that that's something we can work on, right, over time, because you can always work on building your muscle mass back later, right? As another sort of, it's a constant goal to work on building muscle mass, right? It doesn't stop, it continues, year after year, time after time, because you're always fighting against that clock of that muscle mass loss.
I love that. And that kind of, brings us into a little bit more about where the weight loss is coming from. And you and I talked a good bit about this, paper. This is a conversation, again, a clinical practice statement roundtable that OMA put out, and I couldn't summarize it better than this paragraph. So I, wanted to show that whole piece of that conversation. But I think this is what you were saying in words before you knew this existed verbatim, right?
Yeah, so I think that's, I mean, as the looking at sort of the optimizing our patients' well-being by helping them lose preferentially, more fat and helping them gain muscle mass over time is really the ultimate goal. And so again, to assume that that patients can only lose body fat is extremely unrealistic, right? And part of our job is to educate people on that, so they can understand that the goal is to, avoid those unrealistic expectations, because it is unrealistic to think I'm just going to lose my fat and I'm going to keep all my muscle,
But again, I think this speaks to the patient-centered approach and really setting expectations and really, talking with each patient about their own risk and benefit. And, we've talked a lot about assessing a patient before they have their intervention, so that you can say, someone who's got a lot less muscle mass in the beginning may be someone that you're going to watch a little bit differently than someone who's got high stores of both fat mass and lean mass.
And again, they really need to be able to, get adequate protein intake, right? So we talk about that a lot, and having a protein shake if you're not hungry, or having a protein bar, right? Because again, you need to be able to regulate your, some of these medications shut off our appetite severely, fairly significantly. And so we really want to make sure that the goal, as depicted here, right, is for that loss of excessive, fat mass and to preserve that lean muscle. And we do that by really counseling on the fact that you have to be able to eat enough protein. And we do that with our surgery patients, right? For the first, 3 to 6 months of their post-op time period is a lot of, drinking protein shakes and eating a protein bar or something, right? In order to get that protein in, and that focus on eating the protein first in your meal, and not, eating something else first and getting overly full so that you can't, fit that protein in. So again, this education is where we need to focus on, in addition to helping patients do some strength training.
So yeah, again, we touched on this a little bit with percentages, but I do again appreciate some guidance from the OMA on what happens for people who are losing too much weight. How do, we might call that 25, 30%, whatever the cutoff is, but what do we do and how do we monitor that, and what kind of recommendations are we making? I think this document gives some good feedback there.
That's why we wrote this paper, because we were concerned around what's happening with some of the newer medications and some of those patients that may be on that, that far right side of that surgical graph that we looked at, that greater than 35%, fat mass loss, with some of these highly effective AOMs, just like we have that same concern with patients with surgery. So again, recognizing that you may need to reduce the dose, recognizing they may need more dietary intervention, more regular dietary follow-up with the dietitian, in order to really counsel them on making sure that they're able to consume enough protein, to meet their skeletal muscle needs. And then also, really encouraging resistance exercise, which is key. And that's what a lot of people just don't do by nature, in our lives today.
And I think too, a call out to assessment of using body composition analysis in the beginning, so that you know what you're dealing with and you know how closely you need to monitor that person. All right, so yeah, so I wanted to get to, even though we're getting close to the hour, I did say this would happen. I knew it, and I'm okay with it. We will be recording. We are recording. We're going to send this out next week. So if you do have to jump off, thanks for joining. But we're going to keep going a little bit and talk about the feasibility of the body composition methods in clinic, and then round out and end with some of the dietary and physical activity recommendations and what to do in your clinical practice. So you touched a good bit on this. I'd like the simplified version in the most recent algorithm, talking about the factors that we consider. Again, just like BMI, we keep hearing people say, oh, it's easy and we do it, but it's not the best. We kind of hear that about, oh, that's the gold standard, but nobody has access to it, and so I'm sort of sick of that. I want to hear like, well, what do we have access to, and what's something that we can bring to all of the people, right?
And I think that's yeah, that's where I do think that BIA has bioimpedance analysis has a significant benefit in clinic, especially because it's accurate. It's more and more accurate today, especially the highly advanced scales like the one that Sika has. But those more advanced type of technologies are closer and closer to DEXA, to MRI. They're standardized against that 4-compartment model. So, having that level of technology available today, is key, I think, for patients to be able to see all of these numbers and to track these numbers over time.
And then I know you have shared with me a little bit about, some of the challenges and sort of clinical implications of, I wanted to just pull out the three. So the DEXA, BOD-POD, and BIA, that's the ones that I'm hearing most frequently people are using. So what are some of the, not just the way that works, but what are some of the challenges and maybe more difficult components of that? And then we'll get in a minute to what we're looking for when we are looking for those.
Yeah, the challenges with DEXA obviously are kind of obvious in terms of like, it is radiation. I mean, while it's low radiation, you are, being exposed to a low level of radiation. If you don't have to be exposed to that, it's probably better. Not all DEXA machines measure body composition by nature. So in other words, the computer software has to be added to the machine, right? So like, in other words, just to assume that your DEXA machine at your hospital has the ability to measure body composition. It's not always true. You have to verify that. And like we had to actually, when we were using DEXA, my old institution, we actually had to, order the technology for the machine, like order the computer software, which is not insignificant in cost, by the way. And so, like on the order of like $30,000, right, for this additional piece of software. And then, just accommodating patients of higher body weight or body size even, because you have to fit on the table in terms of, being able to do the test, like within the, confines of that space there that's shown in the picture. And so again, it also doesn't always distinguish visceral fat versus subcutaneous fat. And, it doesn't look at water, right? So the biggest issue too is for patients that do have heart failure or liver disease or other reasons why they have excessive extracellular water, it can be challenging, to get an accurate measurement there. And then the BOD-POD, right?
Talking about. It does make sense.
I just can't. We had one of these at the University of Cincinnati too, where I was, in the sports research area, right? They had a BOD-POD, and I just always thought it was so funny. Like, I mean, look at that. You got to put that cap on even. I mean, like, what? Like, I don't know. It just seems very challenging, right, to get in the machine, and so it is again, I think requires a skilled technician, all the things about it. So it's just very challenging to, I think, do it in clinical practice. And then, with the bioimpedance, as we talked about earlier, it's the easiest thing that we have to do in clinic. Or, certainly patients just can have their clothes on. They can, stand on this device. It measures impedance of electrical current through the body. Other than people who may have a pacemaker or an implanted electrical device, there's really, very few exclusions for reasons why they can do this test. The devices that have both hands and feet, as you can see here with the gentleman on the Sika scale here, using, putting the hands on the scale, the feet on the scale, that increases the accuracy of the measurement. And then, again, incorporating the waist circumference and then having a calculation that uses the waist circumference to improve the accuracy of the visceral adipose tissue is the key there. So, and also, the multi-frequency, when you see from devices, they'll say how much frequency, how many frequencies they're using. So the multi-frequency measures both intracellular and extracellular water. So it can help to sort of show when people have extracellular water, which, is more edema, if you will, tissue edema.
And that, I think too, from some of the past research studies, when folks are, looking at that single frequency, just like you said, the technology has improved a lot over the past several years. So if you're looking at research studies, just being aware of some of these factors is important too. And then this was
that
from
not all machines are created equal, right? Sorry, Nina, I didn't mean to interrupt, but that's the thing, is to recognize, the level of accuracy based on some of the research that's behind it.
Yeah, and then you and I had talked a lot about what are some of the factors that you do want to consider in your practice. So this kind of summarizes those for you.
Yeah, especially the weight limit, right? Because that's a big deal. We want to make sure we have inclusive equipment that doesn't, have a limitation for some of our patients that may be upwards of, 500 pounds, right? And then, the fact that the handrails are fixed, so that people can, it's nice to be able to kind of balance there a little bit, on the scale, not have to sort of balance yourself for people that might have a balance issue. We like it when the base of the scale is wide, and it's very important because, meaning you can see those footprints on the Sika scale there are far apart when measuring the body composition. And that's important because, you cannot have your legs touching, cannot have the thighs touching. So it's an important point to make when patients also are measuring themselves at home with their own bioimpedance devices, which are very tiny. Have you seen the scales at home? I mean, the platform is like not big, right? It's like tiny. And so it's really next to impossible for any patient, myself included, to stand on my bioimpedance scale at home and actually have my legs not be touching when I'm naked in the morning, before my shower, right? Which is when most people get on the scale. And so putting some sort of clothing or putting a towel or a pillow or something between the legs, so that there's a material of sorts. For most of our patients in the clinic, it's not as much of an issue because they come in, with pants on potentially that keep that. But women wearing skirts and other types of shorts in the summer, again, we have had some patients where we had to put something there. We use a pillow because it tends to work the best. That they can put it there between their legs so that their skin that you don't want that skin to skin contact. Otherwise, the electrical current's just going to go up and go through to the other leg. So all you're measuring is like the bottom half and not the rest of the body.
Right.
And I do think the ease of getting the data in like this is key, right? I mean, you guys have made amazing improvements on this device, which I love, so that there's very minimal input on the tiny screen you see there. So all the data is put in, via the application, the software on the cloud, which is a huge, I think, a huge accomplishment, versus the old days having to sort of hit a tiny keyboard and type all this, this data in. The nice part too is this little, that little screen you see there is swivelable, and so we can easily turn the screen. So if patients do not want to see their weight, they don't have to get on backwards or anything like that. We have patients who don't want to see that number, and we can just flip that screen a little bit, towards the operator, and the patient doesn't even have to see any of their data.
Yeah, and then for me, the last part's important too, because I spent a good bit of time talking to healthcare providers about how to communicate results to their patients, and some of the benefits I hear is, really wanting to show them the things that support your clinical practice. So, if there's 20 parameters available, if you're not going to discuss all 20, it's going to be kind of hard to get people not to notice them and ask questions. And so you really want to make sure, you're just showing them the information that supports those clinical talking points. And if we do move away from BMI, we have an ability to just customize that very individually for the patient, for the practice. And so without having to, like I've heard from others where they have a big sheet of paper with all the parameters on there and they have to cross it out, and that's not a good look. And so I do really like that the customizable part is there. And this is something we've talked about probably needing another whole hour to talk through. And this is something I do when people, purchase our devices, as I go through a training about the different parameters. But I know it's important to see what are some of the parameters that are available to folks when they do use bioimpedance in their practice. Any comments on some of the ones you like the most?
I love I mean, I do really like our Sika, right? Because of all the things I said. The base of it's really low, it's really stable. People have no problem getting up on it, stepping on it. The ultrasonic height measurement is amazing. People love that. They just stand there and it measures your height. I mean, it's just like futuristic technology, you know? I mean, it's great. But, you know, looking at all these components, especially, you know, we talk a lot about body fat percentage to patients, right? That's really the number that we're trying to normalize, right? I mean, for all intents and purposes, you know, it's that fat mass percent. So you can change that by lowering your fat mass. You can change that by increasing your muscle mass. Because if you increase the denominator, right, that makes the number go down. If you decrease the numerator, which is the fat mass, you know, that makes that fat percentage go down. So, you know, having that fat percentage and also having that, you know, actual skeletal muscle mass and seeing the total skeletal muscle mass, you know, we can show people that they're not losing muscle mass, right? I mean, or they're losing a little bit or losing that, you know, again, we talk about that 70-30 or 75-25 rule, right? That we expect some muscle mass loss, but you're doing a good job because you're minimizing it with what you're doing. And then, you know, we really like the visceral adipose tissue too, you know, because, right, we're really looking at, you know, how much of that visceral adipose tissue is going down, and seeing that go down for patients is really important. I mean, patients love it. You know, they love to, you know, be able to see these numbers get better over time.
And I think I hear a lot, you know, looking at the muscle mass is something that, you know, we don't have a set number. People aren't thinking, oh, this is what mine is supposed to be, but it's really something that I think is both motivating, it's functional, it's getting people away from that. I just need to reduce my size. It's thinking about long-term health, and it's individual. I mean, it is hard, as you know, to increase your muscle mass. So I think that's one that's like really kind of keeping people long-term thinking, and
it really motivates people to, I mean, what I've seen is it motivates people, you know, to really do something resistance based, right? Like to really sort of show them, you really got to do this, you know, like, I mean, it really gets people sort of like motivated to make those changes.
Well, yeah, so let's sort of wrap up with a little bit of, you know, what are some of those diet and physical activity recommendations we can make? A lot of this, of course, as we know in counseling, is individualized and is going to depend on the patient-centered approach and working with them. But what are some of the evidence-based recommendations out there? And this, you know, I wanted to include was just a study looking at, it was a nice study looking at physical activity and high quality protein in a small group of women over 16 weeks. And that really was able to show a decrease in weight, a decrease in body fat without a loss of lean mass when they were doing a good bit of exercise here, 5 days a week walking, 2 days a week resistance training with a 1 to 5 carbohydrate to protein ratio. And then as far as protein intake goes, this one was a little bit more fun, you know, kind of thinking about what are these recommendations. And as Angela, as you and I have talked about, looking at the gram per kilogram recommendations, I've heard lots of providers all over the place with what they're recommending, but and I don't have a full answer of which body weight to use, but looking at some of the different recommendations for protein based on actual adjusted or ideal body weight.
Yeah, I know that's always the big clincher. We've always said in obesity treatment, 1 to 1.5 grams of protein, you know, per kilogram of whatever weight you want to use, right? Which traditionally has been sort of ideal body weight or adjusted body weight, you know, not typically actual body weight, because that would lead to a lot of protein. I like to use their skeletal muscle mass because I have it in front of me from the test, you know, I mean, from the Sika, right, from the body composition.
And yeah, and I thought, you know, as we talked about that, this is from a study looking at that more deeply, where they're talking about using the protein requirement based on fat-free mass and advocating, again, for more frequent measurement to determine protein requirements, especially those who we might expect a different body composition. So in our patients with overweight, obesity, or severe obesity. So again, I don't know that we have a full answer on that of which number to use. I'm happy to chat with folks who may want to write in about what they're doing. But again, I think, you know, my support here is that we are constantly trying to get better, constantly trying to make better recommendations. And if we're able to use this data to make better protein recommendations, I think to me that's another reason to get this information.
Exactly.
A little bit about physical activity. I'll let you kind of take this one.
Yeah. So, we do know that, as we mentioned, that routine physical activity is the goal for everybody from a health perspective, not just from a weight perspective. And we know that increasing physical activity levels are the key to weight maintenance. We know that from a lot of good, the Biggest Loser data, as well as surgery studies. So really helping patients to, reach their lifestyle goals for the focus of greater health and well-being, right, is the key. And so again, really adding in resistance training has been the focus, especially as it relates to people with sarcopenia or patients, that again have lower muscle mass to begin with, or they're wanting to prevent, excessive lean mass loss during weight loss, right? I mean, the key is to really work on that resistance training, which is not innate in a lot of people, right? It's not something most people grow up with. The idea of doing resistance training doesn't come naturally to a lot of people. So really educating patients and providing them an outlet for that. At Knownwell, we just launched our movement medicine program, which is my trainer who is leading sessions, online on an app that patients can follow, so they can have something that they can do, because people just really don't know where to start. So giving them a place to start, I think, is key. I mean, obviously you can use a lot of tools out there, a lot of websites, a lot of different places to go, different Beachbody or whatever, type of plans, that are out there, Peloton, some of my patients have Pelotons, and so they're using that. But whatever they want to use, they need to use something, and they need to, certainly accountability is better, right? If they have some sort of accountability and some sort of follow through for that with health coaching, I think that can be key.
Awesome. Well, and I think the real kind of coming full circle, you and I talked about this last year, really you giving me some of the reasons why you think people should have bioimpedance in their practice. And so I put those down here and thought I'd let you end our talk today with why you think it's as important as you do for other healthcare providers.
Yeah, as we mentioned already, I think bioimpedance provides better data, than just BMI, right? It helps to more over time as well. I think sometimes it's hard to have that first discussion with patients about their results, because it can be quite, patients don't have a realistic expectation of what body fat is, right? And, everybody thinks they have 8% body fat, which we know is like what, not even some of the elite athletes have. So again, to expect all of us to be elite athletes is fairly unrealistic. But yet that's kind of what our expectation is in our minds. So we have to really level set that, and having this data and to be able to talk about that and talk about the fact that, for women, for example, having 34% body fat or 32% body fat can be normal, right? That trying to get to 8% is not necessarily, it shouldn't be necessarily everyone's goal, right? And so,
yeah, I'd be happy with 20, anything.
Right? But I meant the reality is people have this vision, right, of somebody that has a lower body fat percentage, and so we really have to do some education around that. And as we prescribe more of these medications, we really need to be more responsible for helping patients, to not just lose weight, but to lose adiposity, right? And to increase their health and increase their well-being. And really, the fact that we lose skeletal muscle mass every year without trying, right, as a routine, like that's the sort of trajectory that we're on, especially, over the age of 50. I think, if we recognize that and we can work against that, right, that's going to be the goal, educating people against that, or educating people how we can fight Mother Nature, so to speak, is really what we're trying to do. And then looking at visceral adiposity is really what we want to look at from a metabolic health perspective. And so being able to show people what their visceral adiposity is, and then offer them treatment options, right, is what we're really looking at. I think the ability to assess total body water is a key feature with bioimpedance, because it's a good sign of nutrition. It's a good sign of also being hydrated, right? Being well hydrated, and then for people that have edema, right, they can actually see that that's something that's affecting them, and work on that as an overall goal.
Right. And then, yeah, some kind of future thinking as far as, kind of more from a practice management standpoint. We talk a lot about, how are people getting a return on investment in order to justify their purchase?
Yeah, so, obviously you can charge for it. Even if you don't have a cash practice, you can charge for it because it's currently not reimbursable. So even if you have an insurance-based practice like ours, I mean, we've considered, models in which, you might, charge a fee to have it done on a more frequent basis, et cetera, right? We can work towards, we have a motivation at least, I think you and I do, and others, right, to push for the AMA to change there is a CPT code, it's 0358T. The T means it's a test code, which is a level 3 code. In order for it to be routinely reimbursed by insurance plans, it needs to be a level 1 code. So there actually is a process at the AMA, and again, it's one of a good reason for us to have an AMA, delegate seat, et cetera, is that, we really want to get that level 3 code up to a level 1 code. So we can actually petition to do that over time. And so that is one of our ideas, is to work on that over time. It is a extremely arduous process. So it is not without, it's not easy. But the more we have this device and the more we actually drop the charges for it, even if they're not reimbursed, the more it will encourage it to become a level 1 reimbursement. So again, if you have one of these devices and you have the ability to bill insurance, if you drop this charge, even though it gets denied, and it's going to get denied, the more we drop the charge, the more they'll be likely to advance it to level 1 as well. We actually, as we bill insurance, and a lot of our visits are based on time. So when we spend time, reviewing this data, of course, we can obviously, bill for that time, add that into our level of service. So that is helpful there. If you're going for the obesity medicine designation within the MBSA-QIP, one of the recommendations is to look at, assess baseline body fat, body composition as part of the standard of care there. So again, that was, I think, very insightful of MBSA-QIP to want to include that as part of their practice, as we look towards the future of what is high quality care and how we're delivering it.
Well, Angela, thank you so much for all of your insight. I did want to share, some other ways that you can hear from us together. We did a fireside chat that we have broken up, that's on our YouTube page, and I did want to make sure everybody knows how to get in touch with both of us. So we will definitely get to your questions, and we do have some emails scheduled to come out with follow-up. So you will get the recording next week and the PowerPoint slides if you were unable to access them in the handout section here today. And we will get those questions answered. And I apologize for going over time. We'll cut the final one so it's closer to an hour. But any last comments before we let you go back to your practice?
No, thank you for having me. And I'm really excited about the future of obesity care. We have so many, wonderful new treatments coming down the pike to be able to help everybody, right, optimize their health and well-being. And that's what it's really about, is trying to find that optimal place where all of us can live longer and healthier and do that in a way that is reasonable for us all, right? That live into that healthful lifestyle as best we can.
Well, thanks again, Angela. Thanks for having us, and I'll see you at the next meeting.
Yeah, see you there. Take care.
All right, bye-bye.